Welcome to the Macular Disease Society's first Top Doctor seminar for 2012. My name's Helen Jackman. I'm the Chief Executive of the Macular Disease Society. We're absolutely thrilled to see you all here. You're the lucky few who managed to get tickets. This was something of a sell-out event, so we're extremely pleased with how popular it's been. We might have to find a bigger venue if we do this next year. These talks really are part of our 25th anniversary. This year is our 25th anniversary. So the Society's seen a lot of things change over the years. Obviously there's a lot of progress that's been made, a lot more progress to be made. But research and understanding about macular disease is moving apace all the time. And one of the things that we hear from our members is that you're all very passionate to know more and to understand the latest, both in terms of medical treatments and in terms of services and low vision and rehabilitation. So we thought that this year we would put on a series of talks by some local specialists that I think will be known to many of you. And so without further ado, I'm going to introduce our first speaker, Professor Dhillon. I know that Bal knows quite a lot of you because he was speaking to people and talking to, so I'm sure that many of you are under his care. He's been a consultant ophthalmic surgeon at Spires, Murrayfield, Edinburgh and Lothian NHS, and is also an academic and researcher.
So yes, happy birthday, Macular Disease Society, 25 years today, and certainly a great honour and a privilege to speak to you today. And I recognise many faces in the audience, and we've met in clinic, and we've met very regularly for some of you, to the point where I guess we've become fairly close acquaintances, maybe not friends, but maybe extremely close thing. But I would like to, first of all, say that the Macular Disease Society has been a great supporter of research, and in this uncertain time in the economy and dwindling research resources, I think it's even more encouraging that so many of you are willing to support and continue to support clinical research in AMD. And it's mainly AMD that I'll be talking about today. I'll touch a little bit on macular dystrophy, a little bit on retinitis pigmentosa, because some of the advances that are being made in those conditions will have direct relevance in translating some of the research in dystrophies and retinitis pigmentosa into AMD. And yes, the title cunningly termed The Trials, Tribulations and Great Expectations. And there are a few reasons why I decided to call it that, not least because Charles Dickens, of course, in terms of Great Expectations, coined that phrase. But really, it describes the ups and downs of any clinical research project, which by definition we don't know the result of when we start out in any aspect of basic or applied clinical research. The trials that follow are very expensive, they're very costly, and the tribulations and the problems that one encounters along the way are there to be overcome, got round and met, so that at least we can halfway meet the expectations of both yourselves and for everyone who cares for AMD and people with the condition. So going back to the talk, I would like to cover three main areas today, and the topics were really chosen because I've asked some of you as you came to clinic who told me that you were coming today, what you'd like to hear about. And by far the most common request was, when am I going to come up with a cure for AMD? Which I'd love to be able to say I have, but still working on it, me together with an awful lot of other researchers and clinicians. I think the areas that hold promise and the domains that I'll try and cover today are genetics and how improved understanding of genetics and personal genetic profiles can be used and will be used in terms of monitoring patients, particularly regarding therapies that will come on stream, new therapies over and above the Lucentis and Avastin that are used currently. I'll also talk about stem cells, because that was another request that I had talking to some of you. Stem cells is always in the press, it's always on the news, and I thought I could try and put down on paper and also in today's talk exactly where stem cells are going to take us with regard to potential new treatments. And finally, I'd like to discuss something else that's also been in the press recently, and that is moves towards an artificial retina. So rather than trying to regenerate or renew our own retina, different approaches using not necessarily medical science, but microtechnologies, microelectronics, physics, which may enable us to have a retina that is been termed the bionic eye, but it's in an early stage of development at the moment, but I suspect that too will have an impact over the longer term on how we manage individuals who live with AMD. So just turning the clock back to start with, I've been in Edinburgh about as long as the Macular Disease Society has existed. I came here in 1986 at a time when the scene was very different in AMD care. In fact, it wasn't called AMD, it was called senile macular degeneration, not a terribly flattering term, and that's thankfully since changed. And our clinic provision was fairly rudimentary, and the overall approach was fairly pessimistic. So back in the 80s, certainly before the MDS was formed, patients were often told that blind registration was inevitable, that there was nothing to be done, and by and large patients were discharged from clinic without any great follow-up and with a fairly fragmented support and rehabilitation service. So at that time it was clear that something needed to be done, so I think at the Eye Pavilion, where many of you visit, we set up a macular clinic, we set up a retina and genetics clinic, we developed the diagnostic facilities there which have grown, and they've supported and actually informed a lot of the clinical research that certainly I and other colleagues that I work with are doing in Edinburgh. One of those studies you may have participated in, and that is a Scottish AMD genetics study, and that's where I'd like to begin. We wish to find out more about the genes, and in particular the genes that conferred risk or increased susceptibility to developing AMD. And so many thousands of individuals with AMD kindly volunteered to have your eyes photographed in some detail, and genetic testing was carried out with your fully informed consent, and matched with individuals with AMD, we had a similar sized population of people without AMD of a similar age and background. And as a result of the work that we did in Edinburgh and also in many other places up and down the country and in fact the world, and in tandem with the growth in the Human Genome Project, which has tried successfully to decode the genes that we carry, some of which we get from our mother and some from our father, and they combine to really make up what is the central hard drive of our cells. It dictates, it determines things like size, weight, height, eye color, characteristics, and with relevance to AMD, it seems to have a large role to play in who will and who will not get AMD. Now, AMD is, as I'm sure you're aware, is a complex condition. Unlike certain genetic conditions which run true in families where it's either a dominant or another type of inherited condition, AMD is a complex interplay between not only your own genes that you carry within every cell of your body, but also the environment. The studies that have done have led us to the point where we now understand far better what genes confer risk and what genes confer benefit. We're only at the start of this work. There are many other genes yet to be discovered. But the ones so far that seem to confer risk are those related to regulation of part of our immune system. And the way that this works is our immune system is very important to protect us from infection, and it has a major role to play in pretty much every other sphere in our general health. And conversely, when the regulation of any part of the immune system is not tightly controlled, that's when we see conditions, including now, as we know, age-related macular degeneration. And unlike a lot of genes, for example, the genes that produce conditions like retinitis pigmentosa, AMD seems to have a specific subset of genes which we're now able to study. The genes that we have in our cells determine what proteins are made, and that determines how well the cells work. And that can't be truer of cells other than in the eye, because at the retina and underneath the retina, the retinal pigment epithelium, those cells have to keep us going and seeing for a good number of years. And these genes that confer risk of AMD are unusual in the sense that AMD clearly occurs in a time-related fashion. It starts off as tiny little white spots, drusen as they're known, at the macula, and in some individuals those drusen progress to form later progressive disease, either the dry form of the degeneration or the wet form of the degeneration. And of course, many individuals have both dry and wet forms of AMD. And it's the genes that seem to be regulating what's called the innate immune system, one of the most evolutionary primitive parts of the immune system that we have, that becomes a little dysregulated. And the accumulation of environmental factors, particularly things like smoking, and if you have a poor diet at some point in your life that's prolonged, that is meaning that your body isn't getting the essential nutrients, the antioxidants, the lutein, the mesozeaxanthin, and these very complex family of chemicals that we can only actually ingest. We can't make these important micronutrients. And if we have the full house of genetic susceptibility, a trigger in the environment, then there are other triggers, for example, exposure to ultraviolet and oxidative stress. All these things can conspire to produce macular degeneration. So knowing that, you might well ask, well, okay, we know that you've got these genes, and maybe some youngsters these days, if they are interested in the condition, might actually have their genes tested, possibly, possibly not. They might then take lifestyle decisions. They might decide never to smoke, always to have a good diet, always to have a healthy weight, and to take regular exercise. These things might encourage folk to adopt exactly those strategies. I suspect it might not. I suspect it might cause a lot of worry and anxiety. But having said that, genetic profiling of this type is now becoming available. Even on the internet, you can have your own gene screened for the AMD susceptibility and the protective genes. Perhaps a more important role for individuals with AMD today will be trying to use genes to predict how individuals respond to AMD therapy. At the moment, we use Lucentis for wet AMD. There will be other drugs and formulations coming on stream. For example, VEGF trap is going through the regulatory processes. It's a drug which, rather than being injected every month, is injected every 2 months and seems to be equally effective. And it has, like all drugs, a small risk profile. But over the coming few years, there'll be many other drugs, usually The plan is to inject them, but there may be other ways of patients taking these medicines. And so if your genes or knowing about your genetic profile can predict which combination of drugs or which single drug you will have the best result with in terms of vision and reduced risk profiles, then that would obviously help tailor treatment to the individual. Because at the moment with Lucentis, we know, for example, that some people will gain some vision, some people will remain stable, and some people will continue to lose vision. And at the moment, we can't identify very well which patient will fall into which group. Of course, in terms of monitoring, there is a lot of research work being done on how best we can identify progressive disease, whether it be dry or wet. A big concern for those individuals that have dry disease, for example, is knowing when their disease might also develop a component of wet disease. Clearly, it'd be nice to offer hospital visits to monitor this very regularly, but sadly we don't currently have the capacity to meet an immediate clinic response to every individual. And if there's a method of monitoring the condition yourself at home, I think that would be useful for some individuals. And there are now, of course, new tools to do that. We rely currently on the Amsler chart, which is the crisscross grid that many of you will be familiar with, in order to try and identify new areas of leakiness or progressive disease. We know that there may be methods that are more sensitive and more specific that are being currently tested. Some of them involve electronic gadgetry, others don't, but this, I think, will have a big impact on how we can ask people with AMD to let the hospital know at an early stage when it's likely to change, and that might alter the treatment that we're then going to offer the individual patient. The other thing that we can use genetics for, if we understand the basic mechanisms of why people develop the disease at the genetic level, is to then try and identify better targeted drugs at a point in time for the individual which prevents them progressing to the more severe types of disease. We know already that you're far better in terms of your vision and your visual outcome if you're having Lucentis, if you get to see your eye doctor as soon as possible after the onset of the symptoms that you're noticing. And the reason for that is that the term wet refers to a leaky spot under the macula. And if that leaky spot is relatively small and well-defined and confined to a tiny area, if that tiny area is then dried up with an intravitreal injection, then you're far better off for your vision. It's far less likely that you'll need ongoing treatment, as compared with if we pick up individuals at a late stage where there's a large leak. It's difficult to stop the leak without them then subsequently being a lot of scarring. And for those individuals, the outlook is not so good. So a key point is to try and identify potentially treatable disease at an early stage. And if we wind the clock back, the more we know about the genetic risk, the more we know that certain individuals will be at risk of developing wet AMD at an earlier age, perhaps the more closely we can then follow them. And more importantly, in the next few years, we'll have strategies to try and reduce progression at an earlier and earlier stage. So hopefully we won't have to wait until somebody develops advanced wet disease before we start to think about treating them. So moving on from genetics, stem cells was the second on the shopping list that folk wanted me to talk about. Essentially, there are different types of stem cells, and a lot of the media coverage gets confused between the different types. The initial discovery of embryonic stem cells, which was some years ago, was a landmark discovery. In fact, one of the authors on that paper worked in Edinburgh, Professor Kaufman, in anatomy. He's since retired. And what he described, initially in mice, were certain cells within the mouse embryo that were necessary to produce in later fetal development every single cell and tissue in the body of the mouse. It was later found that all animals, including us, ourselves, humans, have the same embryonic stem cells, which have a particular property. And that property is that they can replicate, they can divide, and one of the daughter cells then becomes another stem cell. And one of the cells then goes down a different line in terms of developing into a specific part of bodily tissue. And that capability to reproduce itself and produce another stem cell, if you think it makes sense, because we need that pool of cells when we're growing. But in terms of do we keep our embryonic stem cells, the answer is no, we don't. The embryonic stem cell technology that we have is moving forward at such a great rate that currently, and I'm sure you're aware of this, there are clinical trials looking at embryonic stem cell derived cell lines for use in Stargardt's disease and also in dry age-related macular degeneration. The way that it's important to approach any research, particularly related to stem cells and generally related to any invasive treatment, is it has to be proven to be safe, it has to be proven to be effective, and it has to be shown that it's affordable, and in that order. So in terms of safety, clearly if a stem cell derived population is being injected under the retina, which it is for the current trials, the idea being that those embryonic derived stem cells then develop into retinal pigment epithelial cells. These are the cells that are essential for the photoreceptors. That's the layer of cells which includes the rods and the cones. It's important that the retinal pigment epithelium is healthy to keep the photoreceptors healthy. And so the idea behind the trial looking at Stargardt's and dry AMD is to try and provide the eye with the cells that it needs in order to maintain and regenerate its retinal pigment epithelial layer, which in turn hopefully will lead to improvement in the photoreceptor health in the macula. So safety is a concern because unless these cells are behaving in a way that we want them to behave, because we don't want them to produce other cell types other than the retinal pigment epithelium, we don't want them to proliferate and produce disease that's uncontrolled. In order to establish that, then safety is paramount, and that's one of the aims of the current trials. The next type of stem cell is the adult stem cell, which sounds like a contradiction in terms, but the adult stem cell population has one unique property. It can really only regenerate potentially the tissue type in which it lives. So, for example, in Edinburgh at the moment, we have a limbal stem cell trial where we're trying to replenish or regenerate the layer, the epithelial covering of the cornea. And this limbal stem cell population, which we have sitting around the edge of our cornea, slowly produces the cells necessary in the corneal epithelium to maintain a healthy, comfortable eye. And that is a different population of adult stem cells to the ones that we find in the retina. And undoubtedly, they are there. They have been identified. There aren't many of them, but if we can replicate the type of model of approach that we're using for limbal stem cells to retrieve adult retinal stem cells, possibly from people who are generous enough to donate their eyes, and grow them in a laboratory, much like we're doing with limbal stem cells, and then transplant them into the patient, that I think would offer great potential. So the third type of stem cells that I'll talk about is very different to the ones I've already mentioned. They were recently described in Southeast Asia, and the presence of them has been confirmed, and they're not really present in our bodies at the moment. They're made in a laboratory, and the way that they're made is by taking a skin biopsy and taking that skin tissue, putting it in a laboratory and reprogramming the DNA in order to encourage that skin cell to revert back to an embryo-like state, which sounds like science fiction, but it has been done. We're doing it to look at a condition called late-onset macular retinal degeneration, which you may not have heard of. It's a dominantly acquired condition which affects some individuals in the same way that macular degeneration affects individuals, but unlike AMD, patients with this condition lose their peripheral vision as well. So you might say, why are we doing this? Why are we reverting skin cells of these patients who have volunteered for the study back to an embryo-like state? Well, what we're doing is turning the clock back, if you like, in terms of their lifespans, DNA, and obviously the skin cells that we're taking are from individuals who are 40, 50, 60 years old. We encourage them to assume a state that they assumed when they were embryos, and we're using that to then study how we can alter the function of those cells. In fact, it's the retinal pigment epithelial cells that we're looking at closely to see how best a drug or a vitamin or a supplement might encourage those cells to last a lot longer than they're doing at the moment. So that third type of stem cell technology may be useful in terms of transplantation at some point in the future. I suspect we're a lot closer to understanding how to control stem cell biology in individuals. It is going to take a lot more work and over a long period of time before we can say any of the three types of stem cells that I've mentioned are safe, effective, and affordable in large numbers of individuals, but I think it does hold great promise for the future. And so finally, I'd like to just say a few words, because Alan's turn is next, and he's looking at me as if to say, hurry up, is the artificial retina. And of course, microelectronics is a great thing. I remember when we first had our black and white TV, I think it was in the 1960s, and it had big valves and the picture was very fuzzy. But TVs have moved on, and so has microelectronics. And it is now possible to build a microelectronic photosensitive array. And this photosensitive array is quite cunning because it's very small. It's implanted underneath the retina, and it kind of hijacks the nerve layer overlying the retina in order to bypass the photoreceptors. And some individuals have undergone clinical trials as there are active patient recruitments going on. I think Oxford is probably the nearest place that's offering this as a trial therapy. And using a spectacle-mounted camera and wireless communication, the visual images are streamed to the artificial retina, which then links up with the overlying nerve cells in order to get the visual information back to the optic nerve and to the seeing part of the brain, which is at the occipital cortex, so right at the back of your head. And just like black and white TVs, I guess, technology is moving apace, and these artificial retinal implants will be refined, the arrays will be smaller, and I foresee that in turn will be of great benefit to patients with AMD. And so in the final minute, I would just be, 5 minutes. Okay, in the final 5 minutes, I want to give you another vision of the future. And for those of you that have heard of the film Back to the Future. I want to just wind the clock back just for a second, back to the 1980s. And before I came to Edinburgh, I worked in neurosurgery with an eminent, actually Edinburgh-trained neurosurgeon called Ted Hitchcock, who you may not have heard of, but he did some pioneering work in Birmingham, where I worked at the time. And he was a great innovator, and he was ahead of his time, and we obviously need folk like that. He developed a series of electrodes that he had experimented with, and he had several human volunteers in whom he actually implanted the electrodes directly into their occipital cortex. This was without wireless communication, so wires were linked from those electrodes to a camera that was fitted onto the heads of those very brave patients. And whilst I was there, the results seemed very encouraging, and this was for individuals who had no vision at all, and they were able to see, inverted commas, light and dark, which in itself was a great breakthrough. However, as you might expect, complications like infection were a problem, and so those electrodes had to be removed. Interestingly, that technology is now being revisited, and microelectronics and microchips are being developed, which are much smaller, which can be implanted far more safely and have wireless communication. So there are no cables running out of the back of the heads of the experimental animals or subjects. And it's likely that that, in turn, will also be of great benefit, but it's not something that is a mature technology at the moment. I think it's something that will require the close cooperation of medics, physicists, bioengineers, electronic engineers in order to push forward. But having said that, I think the thing it really needs most is continued support, not just funding, but really the impetus and the drive of folk like yourself in the MDS, not only to highlight the importance of this work, but also you've been very generous in supporting research and development, and I hope that continues. So if I think my time's just about up. If you'd like to know any more about the eye research we're doing, which is funded through an endowment here in Edinburgh, or if you want to know of any current trials that are happening, then by all means let me know or get in touch. But other than that, I'd like to wish the MDS a very happy 25th birthday and look forward to the next 25 years. Thanks for listening.
Alan Suttie is the Chief Executive of the Fife Society for the Blind and has been a specialist in the field of low vision and visual impairment for over 30 years and is going to talk to us about low vision services. Thank you, Alan.
Well, thank you very much, and thank you to Bal for that kind of introduction. Now, it's appropriate that I should be following Bal, because rehabilitation really comes into play when you've seen Bal and he says to you, unfortunately, there's nothing else I can do for you, and he kind of hands you on. So that's why it's a kind of an appropriate order. Now, in order to understand rehabilitation, what I want to do is to kind of start with thinking very simply in my layman's terms about vision and sight loss. And I'm going to use you, the audience, to help me. Now, I'd like those of you right on my left-hand side, right against that wall, so on your right, I want you to imagine the days when you had good vision, when you could see, you could go to the optician and you could get all the way down the eye chart. And there are really two things about having normal vision. The first thing is, when we have normal vision, we can see things clearly, and we can see things clearly when they're far away. We can see things clearly when they're smaller and they get closer to us. Unfortunately, for people like me, when I've got my spectacles on, I can also see clearly large things and small things, and I can get right down the eye chart, and it still allows me to drive a car. Now, the other thing about being normally sighted is that we can see a complete picture. So when I stand in front of you now, my field of view, as we describe it, is 180 degrees. When I look straight ahead, I can see the whole room. And that, to me, is normal vision. And those of us, as I say, with spectacle correction, we're over on that side. Now, I want to imagine those of you right on my far right-hand side, those of you on your left. Just imagine for a moment that you're totally blind. You can see absolutely no light at all. Now, in my job, those of you right on that right-hand side, it's only about 5% of the people we work with. There are very, very few people who are totally blind. And most of those people are people who've been totally blind since birth. There are very, very few people who, and they tend to be people who have a very sudden or traumatic loss of vision, end up totally blind. So that's quite reassuring. So if you started off on my left-hand side and your vision's progressively getting worse, and Bal says to you, well, you're not going to totally lose your vision, he's quite right. You're not going to end up on that far right-hand side. So that means that most of the people that I work with in terms of rehabilitation are somewhere here in the middle. And there's kind of two things that go wrong. One is your ability to see things clearly, or your visual acuity, begins to deteriorate. And that perhaps means that you're waiting at the bus stop, you see the bus, but you can't see or read the bus number. You've got that microwave meal out of the freezer, and you maybe just about read the big label, tells you what the meal is, but you can't read the instructions because it's too small. And for many people, gradually that visual acuity gets worse, so you move closer over to my right-hand side, and just before you get to total blindness, there are a few people who have what we would describe as just kind of perception of light, people who can see light and dark, but they couldn't see perhaps the biggest letter on the eye chart. The second thing, of course, that goes wrong is people don't see the whole picture. Now, we get some people who have what we might describe as tunnel vision, so they don't see in the periphery, their field of view, their 180 degrees gets smaller and smaller. And we get some people who can't see in the middle, maybe many of you in this room, so your central vision starts to go. There's a group of people who can only see down one side, have what we call a hemianopic loss of vision. There are other people who have a very kind of patchy vision, so their field of view, they can see bits and not see other bits. And in my job, what we want to try and understand is what can people see or not see. And when I understand that, what I try and do is place them on that line. Now, are they over towards my left, towards normal sight, or are they over towards my right, towards total blindness? Because that tells me something about how perhaps we can help them. Because if you're on my left-hand side, if you're close to being normally sighted, you clearly don't want to associate with that blind lot over on the right-hand side. And if you're over on the right-hand side, you're actually a long way from normal sight. And of course, if you're over on the left-hand side and you're close to being normally sighted, the way in which you want to be helped is to use the residual sight, use what you've got left to the maximum effect. And if you're over on the right-hand side, what sight you've got left probably isn't very effective, and you might have to think about how can I use my other senses? How can I use the senses that I've got left to help me to do the things that I want to do independently? Now, the big problem is that most people are in the middle. And if you're in the middle of that line, you don't know what you are, because you know you're not seeing as well as you used to, but you don't see yourself as being totally blind. And the difficulty with being in the middle of the line is you probably use a combination of the two. Sometimes you will try and use the vision that you've got left, and other times you're going to have to work using your other senses. Well, that's difficult for you, but it's equally very difficult for those around you, your family and friends, because they don't understand. You know, it's a bit like, you know how they sometimes say, Granddad can hear when he wants to hear. It's a bit like, I hear the same expression, they can see when they want to see. So you might well go down the high street on your way home and spot that £10 note lying on the ground, but you might trip over the curb. In other words, there might be reasons why you can see some things in certain situations, but you can't see in other circumstances. So the first thing I want to know is, where are you on that line? Because that's going to tell me a little bit about what is the kind of methods that are going to help you. Because to help you visually, and I'll talk about them a little bit later, are what I describe as the 3 Bs. 3 things I can do, and that's big, bright, and bold. If we can kind of manipulate those 3 things, we might be able to help you to use the sight you've got left. If you're over towards the non-visual side, then there are really kind of 2 senses which are important. One is our sense of hearing. But of course, we have to remember as we get older, it's not just our sight that starts to fail. For many of us, it's our hearing as well. But there are many things we can do using our sense of hearing. We can have things on tape. Many of you might have things like talking books. We can have things that talk to us, like talking weighing scales, talking watches and clocks. Or we could use our sense of touch. So we can have things that we can feel, and some people might think about using Braille. So those are methods which are non-visual. But what I want to suggest in the presentation tonight is that I think there are many reasons why the kind of rehabilitation you might be offered, wherever it is you live in Scotland, is probably not always appropriate. The first reason it's not always appropriate is most of the things that we, in my business, have traditionally provided are non-visual solutions. So when somebody comes to offer you assistance, if you get offered assistance, they might offer you a talking book, non-visual solution. They might offer you a white cane, non-visual solution. And you're thinking, well, I've got some vision left and I want to try and use it. So I would suggest that the solutions we're offering are not always meeting the needs of people with macular disease. I have to be very careful with my next comment is that most of our rehabilitation services are geared to younger people. And I'm very grateful that there was a previous reference to Stargardt's, because my wife has Stargardt's and she gets most offended if I talk about macular disease as always being age-related, because she started when she was in her teens. So we do remember and acknowledge that for many people it's not necessarily something which is age-related, but for the majority, and for the majority of people that I work with, it is. And many of the rehabilitation services that have been developed over the years are things which have been developed for younger people. Long cane mobility, when it was started because there were people losing their sight in combat. So they were young, fit, able soldiers who were losing their sight and they wanted to get about. And they developed this system. There are young people in school and education and employment who want to learn things like Braille to give them that job, to give them the chance to an education. And I would suggest that those are things which are particularly geared to meet the needs of that younger, very poorly sighted group of people, and not necessarily always older people with macular disease. The next reason why I think that the services we offer are not always appropriate is we do not take into consideration comorbidity. And by that I mean sight loss doesn't always come on its own. And those of us who provide rehabilitation need to consider the person as a whole. On Saturday, I was celebrating a recent 60th birthday. So I'm very pleased to say that the journey I made from Fife to Edinburgh is the first time I got to use my senior rail card. And I was chuffed to bits that I got a third off the price. And on Saturday, I'm always a bit worried about my wife because every time I have a significant birthday, she buys me something. And I always think perhaps she's just checking the insurance policy first, because what she bought me for my birthday was a helicopter flight over Edinburgh. And I think, well, it's going to be hang gliding or something at my next birthday. But I'm already experiencing, and my office is telling me all the time, that my memory's going. I forget what I'm doing, I forget where I'm going, I forget where I leave things. And memory loss is a problem for many of us as we get older. But in fact, having a good memory is very important if you've got poor sight. Because you have to remember where you've left something. You have to remember that phone number you can't easily look up. You've got to remember sequences in a route or sequences you need to follow in carrying out a particular task, because it's not so easy doing that task without vision. But we don't always take that into consideration. I've already spoken about hearing loss. We recently did a study in Fife where we tested dual sensory loss. So we tested people for vision loss and hearing loss in residential care homes for older people. And of the random selection of 100 people in 7 care homes, we found that 75% had sight loss and hearing loss together. So it's important that our rehabilitation takes into consideration the needs of those two together. For many of us, it's also about getting frailer. So maybe having a long white cane isn't appropriate if what you need is something to support you and keep you steady and stable when you're moving about. So I don't think always the things that we provide in rehabilitation necessarily meet the needs, particularly of older people with macular disease. Okay, well, what services might you get? And are they applicable? Now, if you're lucky, one of the first things you might well get is a magnifier. And we have quite good services in most parts of Scotland. You'll get a magnifying device. And they come in all shapes and sizes. But is that always helpful? Because once you're offered a magnifier, if that's the first thing that you're offered on this kind of sight loss journey, whatever the power, whatever the type, that's the solution. And it's very easy to become fixed. Well, that's the only thing I can use. That's my solution. It's this magnifier. And that magnifier, when you're trying to read, it might be a bit slow, it might be a bit cumbersome, it might not do exactly what you want, but that's the solution, and you're fixed on it. But alternatively, you might be offered a magnifier, and you find it doesn't work. So you just give up. You say, well, magnifier is no good for me. I'm going to have to move on, or I'm going to have to put up without reading. So I would suggest that there's always a problem if your first solution is a magnifier, because it either fixes you in a way of working, or it kind of removes that option as a potential for the future. So what's going to be really useful to you? And I know from conversations with many of the people we work with, and I know from a recent conversation I had with Bal, that one of the most important things, and one of the first things you need, is somebody to talk to. Because you've got this bad piece of news, because nobody wanted macular disease. You want, first of all, to understand it, understand more about it, understand what's going wrong. And unfortunately, Bal hasn't got time for that. He's got a big waiting room full of people waiting to see him. So he's going to be reliant on other people to give you that time, to give you that explanation. And you also probably want a bit of support with actually dealing with that shock, dealing with that loss. Because there might be things that it now prevents you from doing. And I know from the years that I've been working, one of the big things is if you had a driving license and you've had to give it up. So it's the loss of the independence that's given. So it affects people in different ways, things that you feel you've got to stop doing, things you can't do that you did before. And that's a shock. It's like a bit like bereavement. You know, something's been taken away. And so you need a little bit of help and support to deal with that. And very often that support will come from other people who are experiencing the same loss that you're experiencing. So peer support. And that's why societies like the Macular Disease Society is such a great institution, because it's bringing together people with similar experiences to share those experiences. And when someone new comes along, you can support those people and you can share with them your knowledge and your understanding. And that's really then to help people to adjust to new circumstances so that they can then move on and progress through that kind of journey of rehabilitation. And I think part of that is also what I started with, that understanding. The number of times when I talk to people about sight loss, they've never really understood that relationship between visual acuity, seeing things clearly, and visual field, losing part of that picture. Because we always tend to think about poor sight as just having a kind of fuzzy picture. And it's not as simple as that. So a little bit of explanation, a little bit of understanding of what's gone wrong, what's not working properly, and why you can see certain things in certain situations and not in others. Okay, let's go back to those 3 B's. And the first was B for big. How do we deal with size? Well, the first thing we want to think about is your bra. Now, don't get excited, gentlemen. I'm not talking about a lady's undergarment. I'm talking about what we would describe as your best retinal area. Now, which bit of your picture is still intact? Which bit can you still possibly use, maybe in a different way? You've got to view a bit differently, what we would describe for some people as eccentrically. Is there useful vision that we can help you to use better? And that really should always be the starting point. The second thing about size, and it again comes from experience over many years, is we often think about going back the way from your optician, because I'm sure many of you, like me, you start with what we call single vision lenses. Some of us progress to bifocals. I'm now down to varifocals. And if you're only seeing a little bit of the picture, and you're using that little bit of the picture, and you've got varifocals, lenses, so when you're trying to read, you're only looking through a small part of the lens, that may be very difficult. Whereas if you go back to a single pair of readers, you may find that much easier, because you can actually use the whole area of the lens. And then the other thing about size, which we often ignore, is we can actually see things better when we hold them closer. The image on our retina gets bigger the closer we get, and yet we're always very reluctant to hold things closer. And that's because our mothers told us, don't hold the book close to your eyes because you're going to strain. My mother used to say, don't read under the bedclothes with a torch because you'll lose your sight. Well, they're just nonsense. Don't take any notice of what your mother's told you. You actually can't damage your eyes by using them. And holding things closer, we can get spectacles. They're called hyperoculars, very high-powered lenses, which means we can have the magnification within our glasses. It leaves our hands free. So it's much easier to work if you're not trying to hold the magnifier, hold the newspaper, hold the crossword, but get it in very close, much closer working distance. So for big, all those methods, but think about bringing it closer, think about maybe getting it bigger, or think about magnifying it. The next is B for bright, and this is always an interesting one, because an interesting kind of statistic that when we're aged 60, we actually require 3 times more light than when we were aged 20. I suspect there's something about the eye is getting very old and scratched and dirty and worn out and perhaps needs more light. It's a bit like an old camera, I suppose. To get a decent picture, we need a lot more light. But of course, many people then say, but as we've seen today, well, I want the blinds drawn, I want the blinds down because I'm struggling. Well, that's a difference between glare, which is that uncontrolled light, and having good light. And so we really need to understand light, and we need to use it and control it for our benefit. I remember going to see a lady in Kirkcaldy many years ago, and she told me that she'd stopped reading the local newspaper. She hadn't read it for 3 years. And I remember going out to my car. I got a little angle poised lamp. I set it up in her living room. No magnifiers, nothing else. I had her reading the newspaper again, just by providing a decent light source. So think about maybe bringing the light in closer, using different sorts of light so you don't get glare, you don't get reflection. Think about where you sit in a room. And obviously this room is not ideal for you sitting. We should have been the other way round, so you had the light coming in behind you or just from the side. But think about it in your living room. And unfortunately, living rooms aren't designed appropriately because we tend to put the television against the window and we sit facing the window because that's where they put the television aerial socket. Because if you put the television opposite to the window, of course, you get the reflection from the window. But in fact, the best place to sit in your living room is over by the window with your back to it. And even on a dull day, natural daylight will give you 4 times more light than artificial light. So artificial light, bring it closer, use natural daylight. And of course, always remember that most light in a room is reflected light. So think about your decoration. Think about whether the walls, the curtains, everything in the room, if it's very dark, will just tend to absorb the light. But if you've got light decoration, it will tend to reflect it. And where you've got this problem with glare, and particularly when you're outdoors and it's bright and sunny, then we have the importance of UV filters. And I see a number of you using ultraviolet filters. These are a great solution because before we started using them, people used to just wear dark glasses. And the problem with just ordinary dark glasses, it cuts out the useful light, it cuts out the useful rays of light. UV filters cut out the harmful rays and allow the useful light to come through. The final B for bold. We can always see things better when they present as having good tonal contrast. So for example, if you've got a daughter who lives in Australia and you write your letters on that blue AML paper in your blue biro, you're going to find it difficult to read what you've written. Whereas your black felt pen on white paper, it's obvious. So your task, what you're trying to do is to give yourself lots of contrast. And I remember once talking to and it was a head teacher in a little primary school who was losing her sight, and she thought she was going to have to give up because apparently in the schools they only give the children pencils to write in their jotters. So she was trying to read grey pencil in the children's jotters. And I said, well, just be ambitious. Just get black felt pens for all your children in the class, and then you'll be able to read it. Then think about the contrast between what it is you're trying to do and the background. And the best example is if you're unfortunate enough to be in hospital and you've got that white boiled fish and white mashed potato on a white plate on a white tray, you can't see anything. So all you need to do is just get yourself a nice brown placemat. So you put your white plate on a brown placemat, then you can see it. So think about how you can introduce contrast just by moving things around, using different colors. Just make a choice. And then the big important thing for people like me, why I spend half my life in meetings, is trying to encourage the people who occupy this kind of city chambers, is when they design the environment outside, is that they use contrast effectively. So when we have pedestrian precincts and you have street furniture, can you see it? When you go down to Waverley Station, can you find your way around easily because the obstacles are strongly contrasting to the background? So just always remember the 3 Bs, big, bright and bold, and if you can manipulate those, then you've got a good chance of maximizing on your useful vision. But remember I started off by saying a lot of the services which agencies like mine have traditionally provided, I don't think are always appropriate. And we need to change the way. Now, there are certain things that I'm going to leave you with. The first thing is the big change in social work, the big change that's coming in my profession is called personalisation. It's about giving you the control, not only over the money, but also over the services, to have the choice. And so what is important is that you ask, you demand the services that you think are going to help you. Don't just accept. So really press. Don't accept being a square peg that they're trying to fit into that round hole. Make sure that people understand what it is that you need and make sure you get the service that you need. And the way to do that is to make sure that you as a group do not remain a silent group. You've got to make your voice heard in the agencies, in the community, and speak up. Now you may say, well, that's obvious, but I actually find it very difficult to get people to actually speak up. You see people who are in wheelchairs, they chain themselves to the railings, they do all sorts of things to protest if they're not getting what they believe they need. But I'm afraid you tend to be the kind of silent group, and you need to start speaking up and letting people know what it is you want, what it is going to help you, and then we can begin to put pressure on the services. There are services that you can benefit from, and I sincerely hope that we can all work together to make sure that you get them. Thank you.